Welcome to The Explainer. Today, we're absolutely unpacking the clinical mechanics of hydrocephalus. We are leaving no stone unturned here, breaking down the underlying mechanisms, the specific causes, and the real-world statistical data so you can walk away with a totally granular, complete understanding of the pathology without ever needing to crack open a textbook. Let's dive right in.
Here's our roadmap for this explainer. We're going to cover 1. Definition and epidemiology, 2. General etiologies, 3. Congenital etiologies, 4. Acquired etiologies, 5. Pediatric etiology data, and finally, 6. Special forms.
All right, starting with Section 1, Definition and Epidemiology, to establish our baseline. So, what exactly are we dealing with? At its core, we define hydrocephalus purely as the abnormal accumulation of cerebrospinal fluid, or CSF, directly within the ventricles of the brain. You can think of the ventricles as a network of interconnected cavities deep within the brain tissue. Under normal conditions, everything flows beautifully. But when the delicate balance between fluid production and fluid absorption is disrupted, this CSF pools up. It dilates those cavities and can put immense, potentially dangerous pressure on the surrounding brain tissue.
Now, you might be wondering, just how common is this? Looking at the epidemiology, the sheer scale of the condition is kind of striking. The estimated overall prevalence sits between 1 and 1.5%. And while 1% might sound like a tiny fraction, when you apply that to the global population, we are literally talking about millions of individuals navigating this structural neurological issue.
When we narrow our focus specifically to congenital cases, meaning the condition is present right at birth, the incidence is approximately 0.9 to 1.8 per 1,000 births. Depending on the reporting criteria and the geographic data, that range can sometimes span anywhere from 0.2 all the way up to 3.5 per thousand. It is a massive, highly significant condition in the world of pediatric neurosurgery.
Let's move smoothly into Section 2, General Etiologies, where we'll look at the 2 functional subdivisions.
Think of this next part as the plumbing aspect of the brain. The mechanisms distinctly split into 2 functional categories. First, we have subnormal CSF reabsorption. This is by far the most common mechanism. The fluid is being made just fine, but it simply can't drain properly. Then, on the flip side, we have CSF overproduction. Now, the absolutely crucial point here is that true overproduction is incredibly rare. You'll really only see it in conditions like choroid plexus papillomas, which are tumors of the actual tissue that produces the CSF. And frankly, even in those super rare cases, the reabsorption is probably defective as well, because a healthy, normal brain can actually tolerate a slightly elevated fluid production rate.
Let's drill down into that much more common issue, subnormal reabsorption. We actually divide this further into 2 very specific types based on where the plumbing fails. First is obstructive, also known as non-communicating hydrocephalus. This is a literal physical roadblock in the pathway proximal to the arachnoid granulations. A classic example is an obstruction at the aqueduct of Sylvius. The fluid is physically trapped, it cannot communicate between the ventricular compartments. Second, we have communicating or non-obstructive hydrocephalus. In this scenario, the fluid travels freely through the ventricles without any roadblocks, but there is a major defect directly at the arachnoid granulations, the exact spot where the CSF is supposed to be reabsorbed back into the bloodstream.
Jumping into Section 3, let's meticulously break down the congenital etiologies.
We're going to cover these causes point by point so you don't miss a thing, starting with Chiari malformations, which are structural defects at the base of the skull. Chiari type 2 is highly significant, and you'll almost always see it occurring concurrently with myelomeningocele, a severe form of spina bifida. We also have to mention Chiari type 1 malformations. Here, hydrocephalus might specifically occur if there happens to be an obstruction right at the outlet of the 4th ventricle.
Moving right along to our next set of congenital causes, we look at issues with the aqueduct. We need to clearly distinguish between 2 things here. First is primary aqueductal stenosis. This is a congenital, structural narrowing that usually presents in infancy. It's super rare to just suddenly discover this in adulthood. Contrast that with secondary aqueductal gliosis. This is actually a scarring or narrowing that is completely secondary to an event in the womb, like a severe intrauterine infection or a germinal matrix hemorrhage that occurred while the fetus was still developing.
Rounding out our list of congenital causes, we have the Dandy-Walker malformation. This is a fascinating structural issue involving the atresia, or complete absence, of the foramina of Luschka and Magendie, which traps the fluid. To put a number on it, the incidence of Dandy-Walker in patients with hydrocephalus is about 2.4%. We also have to note that there are very rare X-linked inherited disorders that cause this. It just brilliantly illustrates the vast, complex array of structural things that can happen before a child takes their first breath.
All right, section 4. Let's switch gears and talk about acquired etiologies, things that develop after birth.
First up are infectious etiologies, and you might be surprised to learn that infections represent the absolute most common cause of communicating hydrocephalus. This frequently happens post-meningitis, particularly purulent and basal meningitis, including those caused by tough bugs like tuberculosis and cryptococcus. Basically, the inflammatory infectious debris effectively clogs up those arachnoid granulations we talked about. We also see this happen with parasitic infections, like cysticercosis.
The second most common cause of communicating hydrocephalus is post-hemorrhagic. Blood pooling in the brain space is incredibly irritating. Actually, scratch that. It's not just irritating, it's highly disruptive. This often happens following a subarachnoid hemorrhage or an intraventricular hemorrhage. Now, while many patients will develop a transient, temporary form of hydrocephalus while the body clears the blood, it is absolutely vital to know that 20 to 50% of patients with large intraventricular hemorrhages are going to develop permanent hydrocephalus that ultimately requires a surgical shunt.
Masses can also physically drive acquired cases, acting like literal roadblocks. We separate these into non-neoplastic masses, like vascular malformations, and neoplastic or cancerous tumors. Neoplastic tumors almost exclusively produce obstructive hydrocephalus by physically pinching off those delicate CSF pathways. Some classic textbook examples include a medulloblastoma crushing the aqueduct, a colloid cyst acting like a perfect little plug right at the foramen of Monroe, or even large pituitary tumors extending upward.
To finish off the acquired list, we need to carefully note a few highly specific situations. First, postoperative complications are a big deal. Around 20% of pediatric patients develop permanent hydrocephalus after having a posterior faucet tumor removed, and strangely, this can actually be delayed for up to a full year post-surgery. Next, we have neurosarcoidosis, which is an inflammatory condition. Then, there's a quirky finding called constitutional ventriculomegaly. This just means naturally enlarged ventricles that are totally asymptomatic and require zero treatment. Lastly, hydrocephalus is sometimes, surprisingly, associated with spinal tumors. Why? Well, it's likely due to either increased proteins from the tumor clogging the granulations, elevated venous pressure, or previous microscopic hemorrhages from the spine traveling up.
Let's look at Section 5, Pediatric Etiology Data, to actually break down the hard numbers.
Rebuilding the exact data from a really prominent 170 pediatric patient series, we can clearly see the distribution, and it tells quite a story. Congenital causes absolutely dominate the landscape here. Congenital cases without myelomeningocele make up 38%, and those with it make up 29%. So if you do the math, a combined 67% of this entire pediatric cohort were driven by congenital anatomical issues present at birth. Far behind that, tumors and perinatal hemorrhage each account for 11%, followed by previous infections at 7.6%, and finally trauma or subarachnoid hemorrhage making up the last 4.7%. Looking at these numbers really puts the massive weight of congenital structural defects into perspective, doesn't it?
Finally, Section 6, Special Forms. Just a quick look at a few other classifications.
Now, to make sure we've covered the whole shebang, we have to mention these special forms. While they are deeply complex, full topics of their own, conditions like normal pressure hydrocephalus, which often presents with that classic triad of dementia, gait disturbance, and urinary incontinence, alongside an entrapped fourth ventricle, arrested hydrocephalus, and triventricular hydrocephalus, all represent the incredible, challenging variants of CSF pathway disruptions. So, as we wrap up this explainer, I really want to leave you with this thought. When you consider the delicate balance of fluid production, navigation, and reabsorption required every single second of our lives, how does the human brain even manage to adapt to such profound pressure changes over time without instantly shutting down? It is a true testament to the mind-blowing resilience and intricate complexity of our neurology. Thank you so much for focused learning with me today, and keep questioning the mechanics behind the medicine.